So in this part of the talk, I'm going to talk about a bunch of different biomarkers that have been studied in bladder cancer. The first is PD-L1. So most immunotherapy drugs that are given for bladder cancer target either PD-1 or PD-L1. PD-L1 is found on the tumor cell and interacts with the PD-1 receptor that's found on immune cells such as T cells. By blocking PD-L1, as immunotherapy does, it ramps up the immune system so the immune system can more effectively fight the cancer. That's also the reason why some of the side effects with immunotherapy treatments occur when the immune cells, because of the ramped up PD-L1 activity, target the cancer. PD-L1 can be measured in both the tumor as well as in the surroundings around the tumor. And high PD-L1 levels are predicted to correlate with response to immunotherapy. But as we'll see, that's not always the case. PD-L1 was first looked at in metastatic bladder cancer. And actually, when pembrolizumab and atezolizumab, two immunotherapy drugs, were first approved for first-line treatment of metastatic bladder cancer, in cisplatin ineligible patients, those patients that aren't able to get cisplatin, they need to have a high PD-L1 score to be considered for these drugs. PD-L1 score was studied a little bit further down the road, and actually now the approval for pembrolizumab or Keytruda that's given for first-line bladder cancer treatment does not depend on PD-L1 score, but it's restricted to only patients in that first-line setting who aren't able to get any platinum drug, including cisplatin or carboplatin. For second-line therapy or maintenance immunotherapy in bladder cancer, those approvals do not depend on PD-L1 score. Now, what is the right PD-L1 score to use for a cutoff of positive and negative? This was actually looked at in one of the early bladder cancer trials that was based upon pembrolizumab approval. So looking at the top, PD-L1 positive patients with a cutoff of 1% definitely did better with pembrolizumab versus chemotherapy in the second-line setting. Whereas less than 1%, some did better with pembrolizumab, but some did better with chemotherapy, hence crossing that line at 1. But looking at a cutoff of 10%, the patients who were greater than 10% still did better, but those who were less than 10% also generally did better with pembrolizumab. So therefore, in this case, 1% is a better cutoff to differentiate what's positive and what's negative in terms of determining patient benefit. PD-L1 has also been studied in adjuvant immunotherapy, which was approved after the results of Checkmate 274. This is for patients who have muscle-invasive bladder cancer, who undergo surgery and have high risk of it coming back, whether they received neoadjuvant chemotherapy or for those patients who weren't able to receive chemotherapy. And they're treated with nivolumab for a year. In this study, the PD-L1 positive tumors definitely had benefit, as shown in the bar on the top. But as the bar on the bottom showed, the PD-L1 negative tumors, in this case defined as less than 1%, also largely benefited. But this might have been an artifact of how PD-L1 was scored. So in this instance, the PD-L1 scoring was based on the percentage of tumor cells that had PD-L1. However, in another analysis of the study, the amount of tumor cells plus surrounding cells that had PD-L1 were studied, and it found that 80% of patients, according to that second score, were positive, whereas only 40% were the first time. And that might explain why the first time some of those PD-L1 negative patients responded to immunotherapy. Which brings me to some of the issues with PD-L1 scoring. First of all, there's a number of different tests used to score PD-L1, and each one correlates with a different drug that might be given. And there's some variability between these tests. Additionally, PD-L1 score can be skewed by clustering of the PD-L1 positive cells, as shown in the picture on top. So in the picture on top, on the left plane, the yellow cells, which are the PD-L1 positive cells, are all clustered together. So if a pathologist is looking at PD-L1 positive cells under a microscope, they're going to say on the left, there's a really high number of PD-L1 cells on the left compared to the right, just looking at what's in that black box. But if you look at the tumor on the whole, there's an equal number of yellow cells, which are the PD-L1 positive cells, and an equal number of purple cells, which are the PD-L1 negative cells. Additionally, as I alluded to in the last slide, there's a few different ways to count PD-L1. Do we just count the tumor cells that are PD-L1 positive, or do we also count the cells that are around the tumor cells that are PD-L1 positive as well? In the bottom picture, on the left and the right, there's the same number of PD-L1 tumor cells. So both of these would have the same TPS score. But on the left, there's a higher number of PD-L1 positive cells overall compared to the right. So on the left, there would be a much higher CPS score than on the right.